Autogenic facial palsy. Let us have a look at what actually happens within the bone before we describe its features and management. The histopathologic changes of facial canal and nerve in facial paralysis due to chronic suppurative otitis media are described in 6 temporal bones that were studied. What did we find? Bony destruction of the facial canal was found in its tympanic segment and its upper mastoid part in all cases, but it was particularly notable in the labyrinthine segment as well. The pathologic process, cholesteatoma or granulation tissue surrounding the exposed facial nerve, was inflamed in all cases. The affected facial nerves showed degenerative and inflammatory changes throughout its tympanic segment in all cases, but its mastoid segment appeared to be relatively normal. These findings suggest that facial paralysis occurs as chronic suppurative otitis when the inflammatory process specifically involves the facial nerve trunk. Facial paralysis as an autogenic complication can originate from acute otitis media and secretory otitis media. The pathologic process in chronic suppurative otitis media causes changes in mucus of middlea manifested by edema, submucous fibrosis, and infiltration with chronic inflammatory cells. Progressive spreading of these inflammatory changes causes osteitis, which provokes invasion and bone destruction of inner ear, dura, or facial canal in development of palsy. The sex of patients is not relevant. The significant data concerns the duration of the disease since 68% of patients have suffered from chronic otitis for several years. Now, this points out the silent character of the disease. The clinical picture of all patients with peripheral facial palsy is identical, no matter of etiology, so they were often wrongly classified and treated as Bell's palsy. Now, that is the reason for imperative examination of middlea in every patient with respective symptoms. Late and inadequate treatment is a common cause of further progressiveness of disease, which causes development of other autogenic complications that can jeopardize the life of a patient. Acute mastoiditis is the most frequently mentioned, but it has also been recorded the most severe complications as autogenic meningitis and cerebral and cerebellar abscesses. It is possible that bacterial toxins penetrate and provoke neuritis with bigger or smaller edema. On the other side, it is commonly considered that facial palsy appears with cholesteatoma of the middlea. Cholesteatoma directly distracts bones and provokes inflammation and also makes compression on the nerve itself. Usually, there is visible bone defects in most cases, that is 84%, but process developed through cracks, and only in 2%, that is 10%, a defect was in the tympanic part of the canal, and in only 5% was facial nerve bare in the tympanic and partially in the mastoid part, 2 centimeters in length. The pathological process was operationally removed without opening the facial canal. And because the removal of the process provides decompression and relief of nerve, the condition often resolves. Operation is followed by medical treatment, and this includes antibiotics and corticosteroids. Now, this treatment of clearance of the disease process results in full recovery in nearly 84% of cases, partial recovery in 10%, and rarely do you come across a patient who have no sign of recovery at all. So the moment we identify the disease and moment we identify potential facial nerve encroachment, we must aggressively go in, clear the disease, and give the patient a lasting relief. Autogenic facial paralysis.